Hello, everybody. Welcome. I'm going to give another minute or so to let people enter the room. I'm glad to see you all here. I'll introduce myself. My name is Dr. Paloma Pedraza Rodriguez. I am a board certified behavior analyst, and I have been for quite some time. This will be my 20th year certified as a behavior analyst. I teach in the applied behavior analysis program, both at the undergraduate and graduate level at FIU, and I've been teaching ABA at FIU for many years as well, about 18 years or so, maybe a little bit less, maybe 16 or 17 years. And I also practice. I practice ABA in the field. I own and I'm the clinical director of an ABA organization that has been around. This is our 18th year in operation. And so I've been at this for a long time. I came into the world of ABA well before most people knew what it was and what it was about. Most of my family members didn't really know what I was getting myself into. And I always had to explain what it was that I was doing. And really the short answer is, I work with kids. I work with kids with special needs. That's really the short version of what it is that I do. But I've been doing it for a long time, and I've had the opportunity to really see the field evolve and change and grow, and all of the good things that have come from that, and simultaneously all of the challenges that have arisen from the recent growth that we've had. And so I've created a presentation here for you. My plan is to spend the next 40 minutes or so going over my slides. And then I plan to leave the last 15 minutes for questions. So as you hear my presentation, if you have any questions, you can put them in the chat. Or you can jot them down, and I will pause at around 45 to look through and answer any of those questions that may come up as we go through. So I'm going to go ahead and get started here. So I've laid out some objectives here for you. I'm a behavior analyst, and so I go by objectives. So at the end of the presentation, hopefully you will understand some of the basic principles of ABA. You'll know what to expect when starting ABA services, and I will point out some of those characteristics of high quality services and point out some red flags that you should look out for. So let's first start by talking about what is ABA, what makes ABA what it is. And so it's important, and I promise I will keep this slide brief, but it is important to understand a little bit of a historical context to the field. Behavior analysis really started off as a philosophy of behavior, understanding behavior as a result of an interaction of genetic and individual characteristics with the environment. And the emphasis being on the impact of the environment and those interactions, basically our experiences, our lived experiences, and how that shapes who we are and what we do. And so this philosophy of looking to context, looking to the environment, developed into an experimental science of behavior, where a lot of research has been conducted in controlled laboratory settings, oftentimes with rats and pigeons, but also with humans, but really to further understand these underlying basic fundamental principles of the science of behavior, which is where we get our concepts of positive reinforcement and things like that we apply. So from the philosophy of behaviorism, from the experimental science of behavior, we derive the field of applied behavior analysis. Now, applied behavior analysis came to be as a result of better understanding of behavior and the variables that impact how we behave and why we behave the way that we do. And ABA really started off as an applied field working with individuals that other areas of psychology, of education, had sort of given up on. Severe psychiatric disorders, developmental disabilities, intellectual disabilities, individuals that had been previously deemed to be unteachable or uncontrollable, who were often institutionalized were now able to receive some services that allowed them to improve their quality of life. In the 1970s, so this goes back to the 40s and 50s and 60s, and in the 1970s, Ivar Lovaas came in out of UCLA and started working with individuals with autism, doing intensive behavioral interventions with 40 hours per week of interventions delivered by graduate students that led to some really remarkable improvements in IQ and in performance, which began the ABA applied to autism journey that we are still on. There are a lot of people that think that ABA was designed to treat autism, and that really is not. There's no truth to that at all. Autism happens to be an area where ABA has been effectively applied, and that application developed relatively slowly until the early 2000s, where essentially some parents of children with autism, like maybe some of you here today, advocated to the government to require insurance companies to cover ABA services for their autistic children. And they won. And this began to spread across the states. This happened state by state. And in Florida, it was in 2009 that the autism mandate came to pass. And so prior to 2009, commercial insurances did not cover applied behavior analysis services. Medicaid did cover some behavior analysis services, but not to the extent that they cover it today. So in 2009, things began to change. It took some time, but eventually, all commercial insurance companies were required to provide or to cover ABA services specifically to individuals with autism. And so now that was a great positive change that happened, but unfortunately, it did leave out some other individuals that would have benefited from ABA, individuals with intellectual disabilities and other developmental disabilities, as well as individuals with some mental health disorders, in particular, some of those behaviorally challenging ones like oppositional defiance and things like that, right? So this is really how we ended up with ABA being the primary and most recommended intervention for autism, is that it is covered by commercial insurance. So ABA was not created for autism. It's sort of the other way around. Autism kind of became a popular area for intervention. Nowadays, there are many ABA practices that focus almost exclusively on autism. And so there has been a shift towards ABA professionals learning more about autism and becoming familiar with this population. I have been working with kids with autism as an ABA professional for my entire 20 years. There are 7 dimensions of behavior analysis that were designated by these researchers, authors, and practitioners in behavior analysis. I'm not going to get into the nitty-gritty of it, but these are the things that you should sort of use to determine if something is truly fitting in the criteria of what is considered applied behavior analysis. And so interventions that are behavior analytic will be applied. They'll be important to the individual that's receiving those interventions. They will be behavioral, meaning they are focusing on specific behaviors that will be either increased or decreased. They will be analytic, meaning we rely heavily on data to make decisions about treatment. They will be technological, meaning there will be a concrete treatment plan and steps provided to implement procedures. It will be generalizable, where procedures that are used are going to be accessible in a variety of settings and to a variety of people. A lot of the work that we do in ABA is implemented by others, by RBTs, sure, but also by parents and by teachers and other members of the individual's family and community. And so we've got to be able to kind of use these procedures widely and loosely. one of the more important dimensions is that it is effective and it works. It works and it makes a real impact. The effective dimension is one that we don't consider to be a scientific question, but a practical one. At the end of the intervention or during the intervention, we often hear these stories about how much better their lives are, how much easier their lives are, how they didn't expect this type of outcome or change, and their lives are tangibly better. And this is not a scientific outcome, but something that we hope to hear from families that we work with. And of course, finally, behavior analytic interventions are going to be conceptually systematic, as in they are based on these procedures and principles that are derived from the philosophy and the science of behavior. There are two general categories of ABA service that you can kind of conceptualize here. There's either comprehensive treatment plans or focused treatment plans. So comprehensive treatment plans are those that are very broad in focus, and they tend to address a variety of skill and behavior domains, generally communication, independence, and social skills, but they can also include focus on problematic behaviors. There's usually some problem behavior work in there as well. Those typically are delivered in between 25 to 40 hours per week. There's also focused interventions, though. So not all ABA is a ton of hours. Focused interventions typically run between 10 to 25 hours per week. They also tend to be shorter in duration. So comprehensive treatment plans can sometimes last years. I've had clients that we've worked with from the time that they were, preschoolers until the time they graduate from high school. So some of our clients will need, different kinds of support throughout their lifespan. Focused interventions are generally shorter. They can last maybe 6 months, maybe less, because they're focused on a particular problem area. So if you have an individual that is an extremely picky eater, if you have an individual that is having a really hard time with toilet training, we can come in and just sort of, provide some intervention, provide some support, take care of that problem, if you will, and then just, fade ourselves out. So two very different approaches here, two different types of treatment plans, and two different kind of categories of intensity and duration here. ABA services can also be provided in a variety of settings. When I started out, almost nobody had clinics. Almost all services were provided in homes. We still do a lot of in-home services, and in-home services can be very beneficial because of the ability to interact with family members and use familiar environments. These days, I see a lot of ABA intervention happening in schools. Services provided in school settings are challenging and limited, generally because you are sort of competing with the agenda of the teacher and the classroom in the school. So oftentimes, if your child has significant needs, it might be best to find a school setting where the individual can receive a more comprehensive or holistic approach to their intervention. Oftentimes, RBTs working in schools are really not doing ABA. They are shadowing, they are assisting, they are supporting, but they are not really implementing therapeutic interventions that will help clients eventually not need services. Nowadays, we do see a lot more higher prevalence of ABA clinics. Clinics are often directed towards early intervention services. Clinics are very appropriate for that type of setting. So a lot of clinics are set up. My clinic is set up like a little preschool classroom. It's a very nurturing and warm environment that is, sort of set up to look like a preschool classroom with a, circle time rug and the calendar and the stations and all the things that you might see in a typical preschool or kindergarten classroom. And that's set up that way to help our clients prepare to enter a less intrusive setting like a typical school or even a specialized school setting. And then finally, the community. A lot of the times that we provide services in home or in clinic, we want to go out into the community with our clients to help them generalize the skills that they've learned. And so I've done sessions with clients in grocery stores, at the mall, at the park, in someone's car, wherever it is that the behavior is taking place, that is where we will go. And so ABA services can be provided in a whole range of settings, and really those comprehensive treatment plans should take place across multiple settings so that we can get that generalization and that transfer. Focused interventions might just take place in one setting. So if we have a problem with our morning routine or our bedtime routine, we might just come to your house in the morning or at night and observe those situations and provide some support until the behavior is sort of improved, and then we fade out. I've mentioned fading out a couple times, and I will repeat that again as we move forward in this presentation, but I do want to make it very clear that the goal of all ABA intervention is to no longer be needed, or to be needed less and less and less as time goes on. So some basic markers that you should look for, some things that will be present in all ABA interventions that are true ABA interventions, are an initial evaluation and baseline measures of behavior. We have to understand more about the individual's needs and their skills and their deficits. No diagnostic report is going to tell us exactly what we need to work on, and no diagnosis is going to tell us what we need to work on. We have to evaluate each client individually and create treatment plans that are individualized to each client. So there is no treatment plan for autism, treatment plan for ADHD. That's just not how this works, right? We have to work with each individual, and we do evaluations, and we get baseline levels to determine our progress. So from these initial evaluations, we will create formal protocols with measurable goals. So we will say we want them to request with this many words, this many times. We want them to be able to label, this many items. We want them to be able to engage in this behavior without problem behaviors. And so the behavior reduction category comes up here, right? We want individuals to be able to transition to the next activity without having a meltdown or a tantrum. And we might set the goal to be such that only 10% of transitions result in some crying behavior. We do know that some crying is normal for a particular age group, right? We also want to include goals for generalization. So especially with services provided in schools or in clinics, where there isn't as much contact with family members, with caregivers, we want to make sure that there are specific goals in place to transfer the skills learned and to transfer that stimulus and instructional control with parents and different caregivers that the child might interact with. All ABA intervention includes data collection at every session. We are eager to consume data. We are data nerds. If you are working with an agency or with an RBT where data is just kind of not that important, or they write down their data at the end of the day, sort of in summary and recap, that's probably not the most effective way of collecting data. So a ABA intervention is going to require continuous data for all behaviors and goals that are being addressed. Treatment plans within ABA are constantly moving. We're constantly changing. And so, individuals that are receiving comprehensive treatment plans, 40 hours a week of treatment, are probably going to need weekly, maybe bi-weekly program updates, because goals are being met regularly. We are constantly saying, okay, we've mastered that. Let's move on to the next thing. When program updates are not updated on a consistent basis, programs can get stagnant, clients can get bored, behaviors can resurge, RBTs can be left to kind of get creative and figure things out on their own, which is not what we want, right? We want programs to be constantly keeping up with the progress that the client is making. We should also look for caregiver training and support. So, what is the plan to include caregivers, um, whether it be, meetings, whether it be observation, whether it be integration, whether caregivers are being trained in a hands-on manner to work directly with their children, or if they're, just going to meet to have sort of updates and conversations with the BCBA. But some form of caregiver involvement is necessary for an effective ABA intervention. And then finally, as I've mentioned before, titration. Titration is what the insurance companies use, the term that they use, but essentially it means that we would be planning to reduce hours and transition services to less intrusive or intensive ones. Um, so, to me, as a behavior analyst and as an owner of a company, we cannot be afraid of reducing hours. We have to want to reduce hours. We'll get the next client when it comes, but retaining clients or keeping hours high, these are contrary to the basic principles of applied behavior analysis. All right, so here's some examples of unfortunate things that I have seen in my time as an ABA professional and oftentimes as a professor. As a professor, I've had the opportunity to talk with hundreds, maybe thousands, it's been a long time, of students about their experiences at the sites that they work, where they work. And so, I've heard from students these sort of horror stories, and unfortunately, they are more common than I would like for them to be. So some examples are things that we've seen for bad ABA, or I would even say not ABA, right? Maybe this shouldn't even really qualify as ABA. Is of course excessive dosage. This is one of the biggest challenges that we have in our field today. You may have seen a recent article published by the Wall Street Journal addressing some of these issues. There are some companies that love the idea of 40 hours per week. And so they give everybody 40 hours per week of ABA, whether they need it or not, or whether it's warranted or not. This is watering down our field. This is watering down the service that they are receiving. And it's very clearly focused on revenue for the company and not the client's needs. Some clients absolutely need 40 hours per week, but I've never had a client get 40 hours per week for more than a year and a half, maybe 2 years tops. We are looking for that titration, that reduction in service and transition. Oftentimes it's, okay, that's enough of this, let's shift it into something else. So excessive dosage is a hallmark of bad ABA. RBTs providing unstructured support, especially without BCBA oversight. So this is sort of what I was alluding to earlier, what I see a lot happening in schools. We see an RBT that's just kind of sitting with the child, oftentimes on their cell phones, distracted, sometimes helping the teacher, sometimes acting as a teacher's aide. I've seen some interesting things in classrooms with 10 RBTs, and they're all just kind of chit-chatting and doing their own thing and really just there to shadow and support the client. But what happens, unfortunately, in these situations, often the client becomes over-reliant on having this adult that's just there to kind of repeat instructions and block them or prevent them from doing things that they get in trouble for. But there isn't real progress being made. There aren't skills being acquired. There isn't a fade out or a transition plan in place. And so it's just kind of having an extra person there. Now, I get that parents like this. I understand that it feels safe and it feels like your kid's getting extra support. But I constantly talk to parents about the dangers of having an RBT present for more than is needed, for things that are really just more for the comfort of the parent or of the client. The other thing that I see here a lot is in private school settings where the school will tell the parents that their child cannot attend the school unless the RBT is present. When that is expressed to families, that should really concern families, because no one should plan to have an RBT with their child indefinitely. And so if there is no opportunity for the RBT and BCBA to make a plan to reduce and to fade, because the school has made a rule that the RBT must be present, then that's not going to be a good fit. That's not going to be an effective plan for that individual. RBTs who don't collect data. So I told you already, we are data nerds. If there is no data being collected, then there is no ABA happening. And if there is no specific treatment plan that is being followed, then there is not ABA happening. So going back to those 7 dimensions, if we don't collect data, we're not being analytic. If we're not following a specific treatment plan, we're not being technological. Um, Unfortunately, I also see a lot of RBTs who rely heavily on reprimands, redirects, response blocking, or restraining as the primary intervention. We understand these to be aversive techniques that rely on coercion, on punishment, on avoidance. And this is really not grounded in science. A lot of times, RBTs are using techniques that they learned at home and are kind of more the way that mom would react or that grandma would react, and they're not scientific and they're not evidence-based and they're not based on reducing those interventions in the long run. And so good ABA interventions are going to leave those types of approaches for the last resource. And finally, agencies or practices that only rely on the DTT method. So the DTT method, discrete trial training, is what you tend to kind of imagine with today's ABA, which is that tabletop, flashcard, fast repetition type of intervention. This is only a small sliver of the range of approaches that we can take to work with children. DTT is an effective strategy, but it should be very limited, short term. It should be integrated with other kinds of approaches. So let's get some examples of what good ABA might look like. And so the first thing we see here is that we rely heavily on positive reinforcement. Positive reinforcement feels good. It is motivating. We want more of it. Positive reinforcers can look different for a lot of individuals, but often we're looking for praise or social interactions to function as reinforcers. Sometimes we have to start with edibles and treats and special activities and toys and things like that, but we eventually shift to social positive reinforcement. We also want to see that we are engaging in proactive and preventative strategies. We don't want to wait for problem behaviors to happen and then react to them. So we put a lot of emphasis on preparing the child for the setting, providing them with all the tools they might need, giving them ways to communicate that are going to be effective for them. Of course, using vocal or non-vocal strategies like picture exchange or communication buttons, AAC, things like that. We want to see flexible, age-appropriate, and dynamic learning opportunities. ABA can look like floor time. It can look like sitting, and playing with a group of peers. It can look like walking through the mall together. They should be age appropriate, not only developmentally appropriate. So if you've got a teenager, they don't need to be doing baby things. You can adapt the types of interactions, the types of materials, the type of play that you interact with that adolescent with, that would give them a little bit more dignity, right? A little bit more age appropriateness. Good ABA should be compassionate and neurodivergent affirming. So one of the biggest criticisms about ABA is that we are attempting to make autistic people not autistic anymore, or that we're trying to make them look normal or fit into normal, whatever the heck that means, standards of socialization and interaction. Good ABA should acknowledge that individuals with autism or autistic individuals, we kind of keep changing on that one, may present in different ways. They may present affection in different ways. They may present anxiety and frustration in different ways. And we need to understand each individual and work with sort of the ways that they communicate. We also understand that problem behaviors, as in screaming, crying, tantruming, dropping to the ground, engaging in aggression, even self-injury, These behaviors have a purpose. They are occurring for a reason. And our job as behavior analysts is to identify those reasons and help those individuals find better ways to satisfy whatever those needs are. We understand, completely that individuals are not manipulative or bad or mean, that they are simply doing the best that they can with the tools that they have. And this applies to autistic individuals, and it applies to all of the clients that we work with. We have the basic assumption that everybody is doing the best that they can with the tools that they have. Good ABA should also be collaborative and team-based, whether those teams and collaborations are within the ABA organization. At the very least, you've got an RBT and a BCBA working together. That's generally the smallest size team. But oftentimes teams will have maybe multiple RBTs. They might have a BCABA and a BCBA. They'll often have maybe some administrative support at the agency. Even better is collaboration across disciplines. So collaboration with speech and occupational therapists, collaboration with educational teams, teachers, principals, school administrators. ABA professionals should be ready and willing and open to these types of collaborations. Good ABA should also have an emphasis on caregiver involvement. So I'll tell you that working with caregivers is the hardest part of working with autistic individuals. And it's not because we don't love you all, it's because you all are stressed. Caregivers are stressed. Caregivers have the most difficult job of making sure that their kids are safe and happy and getting everything that they need. And so working with caregivers is extremely important. It's easy, though, especially in those clinic settings or those school settings, to really be removed from those interactions that the therapist has directly with the client. And so we want to make sure that, as the BCBAs, as the agency directors and owners, we want to make sure that we are communicating regularly with caregivers, that caregivers are involved, that they are participating. And not to mention, the insurance companies also really want to see a lot of this, and it's important that it happens. And of course, good ABA is data driven. We make decisions based on evaluation data, on treatment data. We change the course of our intervention if we see something isn't working. We master goals and say, okay, it's time to move on to something else based on data, not based on how we feel about it. All right, so when you are beginning ABA services, these are some things that you may want to think about. So as I gave the little history earlier, we do now see insurance coverage for ABA services. So first, sort of seeing what kind of coverage you have. Do you have commercial insurance? Do you have Medicaid? There's all kinds of plans out there. Even Medicaid has a lot of different options for it. I don't have all of those details, but I do know that there are differences. And the reason that I placed these two as sort of comparisons is because commercial insurance will only cover ABA services for individuals who have an autism diagnosis. Medicaid, on the other hand, will cover ABA services for a variety of diagnoses. So ADHD, oppositional defiant disorder, other behavioral challenges like that will be covered, but they do require a diagnosis of some sort. Okay, so that diagnostic piece is important to obtaining ABA services. When you're looking to obtain a diagnosis, it is typically recommended that you go to a clinical psychologist. So clinical psychologists are trained in providing detailed reports with the diagnostic tools that they use, with a summary of their impressions and recommendations and things like that. A lot of people will seek out diagnoses from physicians, from neurologists, from psychiatrists. Unfortunately, most physicians, I'm not going to speak for everybody, I've worked with some developmental pediatricians that have been very good about this, but most neurologists and psychiatrists are not going to provide you with a comprehensive diagnostic evaluation. They might write a little script that says, yep, they have autism, and the insurance companies aren't buying that anymore. That's not really sufficient for them. So what they're looking for is a comprehensive diagnostic evaluation that indicates which tools were used and how that diagnosis was determined. Okay, and then there's additional resources that you should tap into. I've got some listed here. I have a slide at the end that has links to these resources. You can ask your insurance company for provider lists for referrals. You can contact Card, which is one of the resources that I listed in the previous group, or join parent groups. I think Miami Moms on Facebook is pretty useful. You can talk to your school team and ask for their recommendations. Anyone who has worked with ABA professionals would be good to ask. If you're on your own, if you're looking at websites, look for certain key things. When were they established? How long have they been open? Who is the owner? Who is the clinical team? Who is the clinical director? Who are the BCBAs? And what kinds of services are provided? And I'm mentioning these things because there are so many new ABA agencies out there, so many that are a year old, 2 years old, with owners and clinical directors that have 1 year of experience, 2 years of experience. Some websites that you find don't provide any of this information. That's very suspicious to me. One of my roles at the university is to evaluate agencies for practicum placements, for internships and practicum placements. And so I review a lot of agencies in the community, and I kind of look for some of these things. And one consistent thing that I find is that those companies that are established, that have been around a long time, that know what they're doing, they're going to be highlighting who their clinicians are, who their top clinicians are. So as you're doing this, you want to ask some important questions. And unfortunately, I'm going to have to go a little quickly through these, but we are going to try to provide some of this information to you after the fact. So you want to ask questions about intake assessments. So which assessments are we going to be using to evaluate? Are you going to evaluate my child directly, or are you just going to interview me and ask me questions? I think it's important that the clinicians meet the client and interact with the client directly as part of the treatment plan development. You can ask how they plan to develop the treatment. If they say, oh, everyone gets the same starting treatment plan, that's a big red flag. That's something to run away from. If you ask how will treatment hours be determined and they say, oh, we start everybody off at 40 hours, that's another red flag to run away from. There should not be a blanket, everybody gets the same thing at any agency. It's not behavior analytic. So there should be some sort of a process to determine. I've gotten calls from clients that say, oh, I can only choose your agency if you can guarantee me 40 hours a week. And unfortunately, I have to say I can't do that. I'm sorry, but I cannot guarantee that I'll give you any certain number of hours until you come in for evaluation. Maybe your child will need it, but we're not a daycare, right? We're not that type of a setting where you can say, okay, you're going to come from 9 to 5 every day. Who will make up my child's team, and what level of support will the RBT receive? So how are you going to kind of put these teams together? And how often will that RBT see the BCBA? Will I have an opportunity to review and approve the proposed plan? Consent is a very important factor in all interventions. And so we expect that parents will have an opportunity to review the treatment plan, ask any questions, indicate any concerns that they might have before that plan is implemented. How will I remain informed about the progress? What is the plan for my involvement as a caregiver? And very importantly, again, what is the plan for fading services and protecting against over-reliance? So these are some questions that you can think about as you're calling these agencies. All right, so these are some things to look for when you're picking those ABA providers. So again, looking for that clinical leadership, BCBA-Ds, doctoral level BCBAs, or BCBAs with substantial experience and training, 5 years plus for a clinical director, at least 5 years. Sufficient clinical support and training. I've seen some agencies that have 1 or 2 BCBAs and 50 RBTs. That's a big red flag. That is not enough support for those RBTs. There isn't really a magic number. You're looking for a ratio, and it also depends on how many hours those RBTs are providing. BCBAs tend to have caseloads of about 6 to 12 clients, 12 being on the high end. Agencies where you see BCBAs that have 20 or more clients are going to be way too stretched thin. You want to see that an agency is going to use a variety of assessment tools and protocols. When I get an intake, I evaluate the client's needs before they even come in for the evaluation. And I pick certain tools based on their age, based on their needs, their communication style, things like that. And so we are adaptive and flexible to the needs of each individual. And you want to make sure that there's already a plan in place for some regular caregiver interactions. Some green flags, some things to kind of go, okay, this makes me feel better. Again, clinical intakes that evaluate those individual needs and determine goodness of fit. I promise you, I am not for everybody. Not all clients will benefit from my services. And so it's important that you find companies that are kind of willing to say, well, this isn't really my area of expertise. Um, to tie into this point, you should expect that good agencies refer out and say, you know what, but I do know somebody else that specializes in this, or let me give you this contact information for another BCBA or for another agency. So agencies that are too eager, too willing to just take whoever and everybody, that's a concern. You want to see, again, individuals and companies that are collaborative and take a team approach. Some green flags are clinical training programs for universities and researcher training partnerships. These types of relationships or partnerships keep companies on the straight and narrow. They keep companies innovative. They keep them on the cutting edge of things. They keep them ethical because students, both undergraduate and graduate students, are learning all the things that they should be seeing. And so if there is a conflict in what they're learning at the university and what they're seeing in their agency, that's going to create some concern for them. You want to see a short wait list or no wait list at all. And that doesn't mean that they're just turning over people quickly. For example, if I'm not able to take a client at the moment, I will not put them on a wait list. I will say, why don't you call me back in a month or two and I'll see if we can fit you in at that time. It is unethical to take a client, evaluate them, and then have them sit and wait for months at a time when they could have spent that time searching for a different agency. You want to find agencies that have low turnover, people that have been working there for years at a time. Turnover is one of the biggest issues in ABA. In fact, I'm doing a talk on RBT turnover at a professional conference in a couple of weeks. And transparency, right? You want companies that are going to be open with you and honest with you and kind of give you the nitty gritty of what's going on. Some red flags, major red flags, companies that are RBT owned or have RBTs as contractors. These are things that the BACB has outright said should not happen. If the RBT owns the company, if they even have a BCBA, that means that they are the boss of their supervisor. So you can see where the conflicts might be there. And RBTs should not be independent contractors because they do not operate independently. They follow treatment plans, they follow guidance and recommendations from BCBAs. And so by definition, they cannot be contractors. Companies do this to save money. That's it. Because they don't want to pay taxes or workman's comp for them. And that's the only reason it happens. And it's very clearly, frankly, illegal. They really shouldn't be doing this. You want to avoid companies that guarantee a minimum number of hours. You want to avoid companies that begin services without evaluation. So someone answers the call and says, yep, sure, I'll have an RBT out there next week. That's got to be a big, like, what? How are you going to throw an RBT in there without an evaluation, without a treatment plan, without, like, how do you even do that? Or companies where RBTs bring their own clients. So I have seen the craziest things. This one to me is one of the wildest. I've gotten calls at my company where, hey, I'm an RBT and I have a 20-hour client. Can we come to you? And I'm just like, huh? How does that? I don't even know how that works. So we don't we don't do this, right? Again, the agency is responsible for intaking the client. The agency will assign a BCBA. The BCBA will evaluate, and then the RBT is added on to the team. I've seen companies give bonuses and incentives for bringing clients in, and that's just not how any of this should work. I know I'm just about out of time here. These are some minor red flags. So these things, if you see them, if it's the only thing, it's probably not that big of a deal, but just things to think about. Companies that provide ABA as an add-on service. So they provide 10,000 services, and ABA is like the 8th or 10th thing on the list. ABA is a highly specialized field. It's not really something that you can just kind of throw in at the end. Insurance companies allow licensed mental health counselors to supervise ABA services. Licensed mental health counselors are wonderful, and we need them and we love them. They're just not ABA professionals. And so if they are overseeing ABA services, you can expect there to be some challenges there. Companies owned by private equity or non-clinical business owners can be a challenge, not necessarily a red flag. There are some private equity companies that are well run. There are some that really only care about the bottom line. And so that is a concern there. And then I wanted to give you all this little hint here for how to find out how long somebody has been certified. So you can look up any individual on the BACB registry, bacb.com. There is a certificate registry. You can type in the person's name and it will tell you if they are certified and what their certification number is. And so that certification number is public information. And that second set of numbers is what indicates the year that the individual was certified. So this is my BACB number, and I was certified in 2006. So this is kind of how you can tell how long somebody has been certified. Okay, so here are those links that I promised to share with you. You can take a screenshot. You can do what you need here. And then again, we'll try to get these links out to you in another way as well. I imagine some of you are taking time out of your workday, your lunch break. So we'll try to get this info out to you in a different way. And then here is where you can find me. So I'll pause here and let's see if I can check the chat. Oh, here we go, Q&A. Okay. Okay, so Eliza's asking about adults with brain injury. Absolutely, this is an area, a major area for intervention. It is a little bit more challenging to find providers for this, but there is a lot of literature with the TBI population. So this is definitely something that is done. I don't know how to help you identify a provider, but I could certainly ask around and dig around if I can help you in that way. As a school social worker, given that the student is experiencing difficulty leaving the home to attend school, how should the team appropriately respond to a parent request for a one-to-one paraprofessional to provide support in home? Well, I mean, I think school social worker, we just know that paraprofessionals are employees of the school. And so, we don't send school employees home to individuals. I would suggest to that individual that they contract an ABA agency and provide some information about getting services in the home setting. Let's see, Rebecca. Regarding practitioners that do CDEs, I would like to point out that PsyDs also do these, not just PhDs. Yes, psychologists in general. Thank you, Rebecca, for pointing that out. Yes, Marta, we will be, this is recorded, and so we should be able to post and share the information. Helping with feeding other than feeding therapy. Sherry, yes, so generally in ABA, our approach is focused on picky or over-selective eating. So there's feeding therapy that typically comes from the speech and language pathology side of the world. Speech and language pathologists will focus a lot on the physiological aspects of feeding, chewing, swallowing, things like that. We see that a lot of individuals with autism and other developmental disabilities may have sensory issues, they have difficulty chewing, swallowing, and so speech therapists will really focus, speech therapists, I'm sorry, who specialize in feeding, will sort of address those concerns. What we do in ABA is focus primarily um, on over selective eating, which we know a lot of kids with autism are very picky. I remember working with a child once that would only eat the hamburgers from McDonald's, not any other fast food place, with no bun, with ketchup, but only that particular ketchup that came in that packet. So anyway, picky eating is a big area of specialization for a decent amount of ABA providers. It's definitely one of the areas that I specialize in. And what we work on is accepting new foods, lowering the barriers to trying different foods, trying different textures, lowering the temperature during meal times. A lot of times, individuals who struggle with over-selective eating, they'll engage in problematic behaviors, tantrums, crying, avoidance, refusal during meal times, making meal times very challenging for the family as a whole. And so we address those types of concerns. Again, making the mealtime experience more pleasant, more enjoyable, and reducing those barriers to trying new foods. The parent frowned on the social worker providing them a list of agencies. I'm sorry to hear that. There is such a there's a lot of challenges out there with us right now with ABA. A lot of people are very afraid of ABA, and there's a lot of bad publicity. And I totally get it. I get why that bad publicity is there. I think that the way for us to move forward is to acknowledge these criticisms, to listen to autistic individuals, to hear their concerns and their stories, and to continue to improve those interactions. But it's very much a don't throw the baby out with the bathwater situation. It is something that people are saying all ABA is torture, all ABA is conversion therapy, and unfortunately, this prevents a lot of individuals from accessing services that could be really beneficial. People who receive ABA services are often treated with a lot of kindness and warmth, and respect and dignity, and often do great things, with those interventions. And so it is unfortunate that we see a general no to ABA. And a lot of times these same voices that are critical of ABA understand that it began with the Ivar Lovaas 40-hour interventions, and don't realize that there is a huge history prior to that. There's a lot of things. Yes, I can, Sherry. There's a lot of things that happened in the Lovaas days that we would not do today. That was the start, and there were a lot of good things um, that came from that, but there were a lot of bad things that, there were a lot of reprimands, a lot of, aversive or coercive control, a lot of repetition, very, not developmentally based, not naturalistic teaching. And so we've learned from those things. That was, over 50 years ago. And so I do hope that we are able to sort of move past this, negative campaign. But most importantly, I think behavior analysts need to be open to hearing these concerns, and learning from those. Um, let's see. Rebecca says one factor that contributes to agencies trying to keep clients at 30 hours per week is the need for RBTs to have stable and predictable schedule. Yep. This is a multi-layered issue from the perspective of an agency owner. How do you manage this balance? It is definitely easier in a center-based setting, more complex when RBTs are traveling to homes or schools. At my agency, the way we manage this is really that the majority, if not all of our RBTs are students. And so they are working part-time, they are taking classes. I understand that this doesn't solve the problem for the majority, of agencies, but being an RBT can be a fulfilling full-time job. But it's hard to find that. It's hard to find a 40-hour a week job as an RBT that's going to be consistent. And so really, you know, in my mind, the RBT position is an entry level sort of temporary position that you use to gain experience, to get your field experience, your supervision, and eventually move on to other roles. One thing that I do in my agency is we actually don't give anybody that many hours, and we rotate. So we split hours between individuals. We'll have RBTs that provide 10 hours to this guy and 10 hours to that guy and 10 hours to that guy, and so that they don't have all of their hours allocated to one specific individual. And so if there are changes, transitions, vacations, illnesses, they're not so impacted by that. And it also gives the RBTs better experiences because they have a broader range of clients and programs that they are learning from and interacting with. Okay, let's see. Can RBTs work together with OT and speech therapy at the same time? Anna asks. So they can, but they often cannot bill. So concurrent billing is a big issue. So oftentimes, if the OT or the speech therapist is billing the insurance company, then the ABA provider cannot bill the same insurance company for the same client at the same time. And so, sometimes we have RBTs that are willing to sit and observe, unpaid for a short period of time. Or there are special arrangements that can be made with insurance companies, generally when behaviors are extremely severe. But I love crossover sessions. I love sessions when the speech or OT will come and sit with us for a little bit, or we come and sit with them for a little bit, which will be really helpful to the client's progress in the long run. So can they work together? Absolutely. Can they build together? Probably not. Okay. I think I'm on time. All right, guys. 1 minute for any last questions. I'm so appreciative of your attention, of your time, of your questions. I really hope that it was useful for you, and that you learned something from this. Again, you can reach out and contact me if you have any additional questions that you would like my help with. On the traumatic brain injury question, please don't hesitate to reach out, and I'll see what resources I can find for you. Absolutely, Anna. Anna asks, ABA may be implemented with nonverbal kids. Absolutely. I have worked with many, many nonverbal kids. I think, specialize really in alternative forms of communication, because communication to us is just another behavior, it's just another form of behavior. And so we understand communication as a broader need than language. Language is a type of communication, but communication is broader. And so, yes, we will work with nonverbal individuals, and we'll work with them to teach them how to express their needs. We work alongside speech therapists, sometimes independently, on picture exchange communication, augmentative communication. Some individuals will use signs and gestures, and of course with vocal communication as well. We will emphasize and try to teach vocal communication as well. But yes, I have worked with many nonverbal kids that eventually gain communication skills, and it's really rewarding. That's probably the thing that hooked me in the most. Getting a kid to talk for the first time, it's pretty magical. Thank you, Elore. I appreciate it. All right, guys. I think I'm going to wrap up this webinar, and I will make sure that the information is passed on to you all after the end of this. Thank you all.